Hello, my name is Gendie Lash. I'm a Principal Investigator in the Division of Uterine Vascular Biology at Guangzhou Women and Children's Medical Center in China. I'm a basic scientist and my research interests are quite varied, but primarily focused around development and remodeling of the uterine spiral arteries across the menstrual cycle and into early pregnancy. Today I'm going to talk about causes and pathogenesis of the thin endometrium. So why do we care about a thin endometrium? Well, as we know, implantation rates in assisted reproductive technologies are relatively low, and research has been focusing on optimizing these implantation rates by focusing on the quality timing of the endometrium for optimal embryo transfer, or IUI. So key to this is being able to identify the window of implantation and also ensuring that the endometrium during that window of implantation is optimal for implantation. So studies have suggested that the thickness of the endometrium during the window of implantation may be a critical factor for implantation, and therefore if we can optimize this, we may be able to improve implantation rates in IVF cycles where there is known good quality embryos. So I know Professor Hull has already discussed this in detail, but really how thin is too thin? And there's a lot of debate about this and controversy, and the definition and cutoff for thin endometrium does appear to differ between studies. However, most studies will use an endometrial thickness of less than 7 or 8 millimeters on the day of HCG administration as their cutoff points. Although pregnancy has been described after embryo transfer with endometrial thickness of approximately 4 millimeters, but the chance of pregnancy in these conditions is low. So how do we assess the endometrial thickness? And again, there's not a lot of consensus on this. And so we do need to start thinking about the best way of measurement, whether that be 2D or 3D Doppler, the best timing of measurement, and what the cutoffs are for management. But in general, it's defined as the distance between the demarcation of the hypoechogenic tissue at the myometrial border to the next border, so across here. So what's the incidence of thin endometrium in IVF? So there's been a few large database studies on this. One of the largest was from the Canadian database, and this included nearly 22,000 fresh IVF embryo transfer cycles, and it suggested that around 12% of these cycles were in an endometrial thickness of less than 8, and only about 4 less than 7. But it also has to be remembered that a lot of cycles are actually cancelled if the endometrium is less than 7. So the number of cycles using an endometrial thickness of less than 7 is in fact lower. When they looked at frozen thawed embryos, and about 19,000 of these transfers, again about 14% with an endometrial thickness less than 8 and 3% less than 7. Depending on the ovarian stimulation cycle, the incidence of thin endometrium appears to be higher and much more variable, and this is dependent on the different agents used, and I will come back to this a little bit later. Again, another retrospective cohort study found an incidence between around 5 to 37% for endometrial thickness less than 7, and 12 to 66% for endometrial thickness less than 8. So these are very, very heterogeneic studies, and so it's very unclear what the cutoffs might be and what the real incidence is, especially if cases are being cancelled. So when we start talking about causes of thinning endometrium, we have to consider how the endometrium grows. So the endometrium is essentially divided into to 2 layers. This is actually taken from a rhesus monkey, but the human looks very similar. There is the endometrium functionalis, and then the endometrium basalis and the myometrium. So in the myometrium, you have the radial arteries, which then differentiate down into the spiral arteries, and then a thinner capillary and spiral artery system into the functionalis. At menstruation, this functionalis is shed and then regenerated from the basal layer. It is assumed that this includes differentiation of stem cells within the basal layer, and also proliferation of the existing cells. For the angiogenesis, you see growth of these blood vessels from the remaining stumps within the basalis. This is just a histograph showing the cross-section of a spiral artery through and the glandular system through mid to late secretory endometrium. All of this is occurring under a profile of estrogen and progesterone, with maximal growth being associated with surges in estrogen. So through the proliferative stage, you have this massive increase in both the glandular networks and the vasculature, as well as the stroma, which includes a number of leukocyte cells, including the uterine natural killer cells, macrophages, and different T cell subsets, all of which are critical for establishment of pregnancy. And then into the secretory phase, where it becomes receptive for implantation. So then what causes a thin endometrium? And really, we can break this down into two main areas: physical causes and hormonal causes. So the physical causes are pretty much all centered around trauma to the basalis, where it is unable to regenerate. So where there is scarring or adhesions, where there's myometrial fibrogenesis, where there's thyroids, or where there's impaired blood flow from the radial arteries. So wherever there is a physical interruption to the basalis, this appears to very severely impact on the normal growth of the endometrium across the menstrual cycle, resulting in it being much thinner than normal. In addition, different hormonal causes alter the profile of estrogen and progesterone, and their relative amounts to each other have also been implicated in thinning of the endometrium. In particular, clomiphene citrate, which is often used in IVF cycles, and we'll come back to some more data on that. And this has been assumed to be due to its anti-estrogenic effects. But there's also some data that women who have used progesterone-based oral contraceptives for extended periods of time, over 10 years, then show a low responsiveness to estrogen, which can persist for years after the cessation of contraceptive use. And there's now emerging also some data on endocrine disrupting compounds, which have become of great interest lately. But a lot of these studies do come from animal models, which use quite high doses for research, and so more epidemiological data will need to be collected on EDC exposure and endometrial growth. So what is the pathogenesis of the thin endometrium? Very little research has actually been done into why a thin endometrium doesn't support most pregnancies. But the overriding hypothesis appears to be that altered blood flow dynamics will increase oxygen and reactive oxygen species at the endometrial interface that are detrimental to implantation. So the embryo likes to implant in a hypoxic environment around 1 to 2%. It's actually normoxic for embryo implantation. And therefore, if there is an altered blood flow that increases the oxygen tension within the endometrium underlying the implantation site, this will severely impact on trophoblast invasion and establishment of the placenta and the pregnancy. Indeed, both spontaneous and recurrent. We may also consider that a reduced glandular network may also diminish the available histotrophic nutrition that's required by the developing embryo prior to development, full development of the maternal fetal circulatory system and remodeling of the spiral arteries. In addition, reduced stromal volume could also alter the key leukocyte populations. In the mid-late secretory phase and into the early pregnancy, leukocytes make up around 30% of all stromal cells. Around 70% of those are the uterine natural killer cells, 20-25% are macrophages, and around 5% are different T cell subsets, including the regulatory T cells. These cells play different roles, from establishment of maternal fetal tolerance to regulating trophoblast invasion and remodeling of the uterine spiral arteries. However, their functions are reliant on key interactions with each other, and all of which are key for establishment and maintenance of the maternal fetal interface. So now I just want to move on to a couple of meta-analyses that have looked at different aspects of thin endometrium. This is a meta-analysis on clomiphene citrate and IUI by Weiss et al. In Human Reproduction 2017. Just an overview of their study and the key papers or studies that they used. So when they looked at endometrial thickness and pregnancy outcome in all of these studies, regardless of the stimulation protocols used, there was found to be a slightly higher pregnancy rate in those women with a thicker, or those women that had a pregnancy had a thicker endometrium than those who did not. But it also has to be considered that many cycles are cancelled if the endometrium is too thin, and this bias is not very clear in these studies. When they looked at the endometrial thickness and the use of clomiphene citrate versus gonadotropins, there was no difference between these two treatment protocols. However, when they looked at clomiphene citrate versus letrozole, or clomiphene citrate in addition to gonadotropin versus letrozole, they did find that that those women taking letrozole had a higher endometrial thickness than those on a clomiphene citrate based protocol. When looking at IVF success, this is another meta-analysis that specifically looked at endometrial thickness and IVF success by Cassius et al. In Human Reproduction Update in 2014. This is an overview of their study, where again they were able to look at 22 studies in detail. And again, there's a very wide variation in cutoffs that were used, from less than 6 to less than 26.7 millimeters. There are also quite a number of differences in the stimulation protocols used and whether or not the treatment was IVF ICSI. So one of their key findings was that endometrial thickness had no discriminatory capacity for clinical pregnancy. So at no one thickness could they say that pregnancy could not be sustained lower than that value. So this makes it very difficult to empirically say to a patient, your endometrium is too thin, we must cancel this cycle. When they looked at live birth rate and using a cutoff of 7, there was no, in terms of odds ratio, while it there was a trend towards that the thinner the endometrium, the poorer the live birth rate. This was not statistically different. However, when considering clinical pregnancies, there was a clear result that those women with a thinner endometrium had a lower rate of clinical pregnancy than those with an endometrium thickness of greater than 7. So in summary, a thin endometrium may contribute to poor implantation rates in IVF, but a lot more consensus is required to determine optimal cutoffs for this, and also the way in which the endometrium is measured, so that there is a standardization in protocols. Further research is also required on the causes of the thin endometrium, and this will aid development of different therapeutic modalities. I know various therapeutics are being talked about after this presentation, but there is still room for novel therapies, and by knowing why the endometrium becomes thin, we can start to look at how we can improve its growth and development across the menstrual cycle. equally, if we know why a thin endometrium contributes to poor implantation rates, this will also help us develop different therapeutic modalities. Thank you very much.